Thank you. Thank you for having me today. As we just said, a novel approach to VBG outlet stenosis. It's a video case of a procedure that we have never seen described in the literature. We place lumen-opposing metal stents in a lot of places, but we hadn't seen this before. My name is AJ Haas. I'm a Metro resident here in Cleveland, Ohio. I have nothing to disclose. So this is an 80-year-old female, and she came to us to our bariatric clinic with years of projectile vomiting that had just gotten worse. She had a vertical banded gastroplasty performed in the 1980s, and although we don't perform this procedure anymore, there's still a not insignificant amount of the population living with this kind of anatomy and are also having diseases or having pathology in the setting of comorbid disease. As you can see, she has a few different arrhythmias, kidney dysfunction, heart failure, and a significant surgical history limiting our surgical interventions. With this VBG, some of them are performed with a scialastic band, and some of them are performed with a Marlex mesh. In our case, it was a Marlex mesh, but in this case series, they had a scialastic band. They were able to use aluminum-opposing metal stent. Here, because there's less risk of erosion, still a risk, but with the Marlex mesh, we thought the risk was too great. So instead, we opted to re-enter the excluded stomach with an axial stent, and then upsize it after about 4 weeks if she tolerated it. So we'll go through that case here. This is an echo endoscope, and we use ultrasound and direct visualization to see the staple line here. We could have gone a little bit lower for our entry point, but playing it safe, we wanted to stay high. And we use 19-gauge needle to penetrate in there and use a little bit of contrast here to confirm our position. We were satisfied that we were likely in the lumen with no other areas that we had entered. We instilled more contrast, and you can see it pooling here in the dependent portion of the stomach. After that, we insert a 0.035 tiger wire, and you can see it here, and we'll follow it down the greater curve of the stomach. Again, gives us indication that we're in the right space. Here I'm going to switch over to the scope view of the echo endoscope, and you see our wire there coming across is our 19-gauge wire, and usually these deploy and they kind of look like a wine glass, but air is the enemy of ultrasound, and we get not too great of a picture over on this side. This is the axial stent that we chose. It's a nitinol and silicone stent. We chose it for these flanges here to kind of hold it in place and prevent or at least mitigate the risk of migration. After we have that deployed, you can see the proximal portion deploying here. We remove our wire, and then we apply some suction and see contrast flowing back into the proximal portion of the pouch. After that, we exchange the echo endoscope for an adult endoscope, and we're able to visualize there through into the excluded stomach. And then going through the native outlet, we dive in an antiflex position, and in this sequence, we can visualize back up into the excluded stomach, and you'll see this other end of the stent here at the top portion of the screen. Getting all the way up there is quite difficult, but we decided that it was an appropriate position from what we could tell there and what we could see on fluoroscopy. After that, we turn our attention back to the stent. And this size it's small, but we could do a little bit better than that. These are deploying with a little bit of pressure, and we use a through the scope balloon and dilate up to a size of 10 millimeters. We could have gone further, but we were a bit cautious as we felt like we've been doing pretty well so far. We didn't want to add any kind of complication. Here you can see a little bit better view into the excluded stomach. And she tolerated the procedure without complication, and she was able to eat soon after and has been eating since. We plan to upsize at 4 weeks, and she did come back at 4 weeks. At time of replacement, we noticed the stent was becoming dislodged, but given that it doesn't have any pressure that's bringing it back down, we felt it was likely due to a small stent just outgrowing its or the size of the fistula outgrowing the stent, so we inserted a bigger stent. These axial stents, we use a 15 by 15. The highest size they have is a 20. I'll take any questions. Thank you.